Hi everyone, this is M.B.B.S nerd, and in this video I'll talk about the pathogenesis and clinical features of iron deficiency anemia. So let's start with the pathogenesis. Basically, if there is increased demand of iron, or if there is increased loss, or if there is inadequate absorption, these three factors, or it may happen that these factors are simultaneously occurring in a person, then these three in combination cause the deficiency of iron in our body that leads to iron deficiency anemia. So, if I talk about increased demand, then increased demand is seen especially in the case of pregnancy. So, in pregnant females, they carry fetus, and the fetus also has to synthesize hemoglobin. So, if there is not, the appropriate nutritional supply given to that female, then that can lead to anemia. Also, if there is increased loss of blood, is there is any kind of hemorrhage going on in the body, or there is some external trauma which led to a loss of lot of blood, or there is menstruation in which there is chronic blood loss is occurring, so that can also lead to the depletion of stores of iron. And if I talk about inadequate absorption, where the body is not losing iron from its stores, but basically it's not getting enough iron because it is not being absorbed properly in our GIT. So this can be seen in cases of intestinal sprue, where uh, the intestine can't absorb appropriate amount of iron. For example, the iron is especially absorbed in the first part of the duodenum. This you should know. So in cases of sprue, the the villi of the intestine are atrophic and they can't absorb appropriate amount of iron. And in cases of achlorhydria, where there is decreased secretion of HCl, so that can also lead to the decreased conversion of Fe3 plus to Fe2 plus. I have talked in my previous videos about this. So this will also lead to the inadequate absorption of iron, and in gastrectomy also, which will lead to decreased secretion of HCl, and that can cause this again, the inadequate absorption of iron. So all of these factors lead to the decreased iron stores in our body. But iron deficiency anemia is not something which presents, just boom and we get iron deficiency anemia. No, it's not like that. It's a very, it is a pathogenesis which occurs in three stages, and it may happen that a person may be iron deficient, but we can't call him that we can't say that this person is suffering from iron deficiency anemia. It takes quite a long time. It may happen that for some time he is not getting adequate iron, but after some time he ingests appropriate amount of iron, uh, and then his iron stores are normal. So yes, he was iron deficient, but now he is not iron deficient. That's how iron deficiency anemia works. And let me explain it through you by the means of serum transferrin and serum ferritin. So in our blood, there are two proteins. There one is the serum ferritin, which stores the iron, and it is, it contains all the iron. It is present in the liver, bone, and then there's this serum transferrin. Now this exchange between between serum transferrin and serum ferritin occurs. Serum ferritin provides iron to serum transferrin, and this is mobile. Serum transferrin moves in the blood and transports iron to the places where it is required. And when we add serum transferrin, the amount of iron in serum transferrin and that in serum ferritin, we get the total serum iron. So when a person is, for example, he is in the state of iron depletion, he is not taking enough iron, or he has some problems in his intestine, or he has a chlorhydra, whatever it is, then he will first start having iron depletion. First of all, his serum ferritin will start decreasing. But you know what? What a magical thing will happen. See, as soon as the serum ferritin starts decreasing, some kind of exchange starts occurring between each of them. Basically, what happens is that this serum transferrin and serum ferritin are in equilibrium. So, if anything starts depleting, especially if serum ferritin or serum transferrin, I mean to say that if the iron in serum transferrin starts decreasing, then serum ferritin starts supplying its stores to serum transferrin. So, this starts decreasing, no doubt, but this starts increasing. So are you understanding me? That if this is decreasing and simultaneously this part, serum transferrin, is also increasing, then this is leading to normal amount of serum iron. So it may happen when you take the reports of such a person that the total serum iron is normal, but the serum ferritin is decreased. Then to spot out the iron depletion in this stage, we have to calculate the serum ferritin. Now, if I talk about iron deficiency, still it is not iron deficiency anemia. So here, the serum ferritin starts decreasing even more, and what happens is that that is not able to, be compensated for that serum iron. It is giving the iron to serum transferrin, but still, since the depletion has occurred to the stage of deficiency, we call it iron deficiency, because if we see the total serum iron also and serum ferritin also, then in this stage serum iron is also low and serum ferritin is also low. And then after this stage, we go into the stage of iron deficiency anemia, where the person has lost all his iron stores and he is very much severely depleted. So basically, if you take the reports of such a person, then serum ferritin will be very low, serum iron will be also very low, and what you will find is that since the transferrin is not saturated by iron, see, I told you that as soon as the iron supply starts decreasing, ferritin starts giving its iron to transferrin. But since this body is also not having his iron, so serum transferrin is hungry for iron. He is not getting that iron. So the transferrin saturation decreases, but the transferrin binding capacity, mark my words, binding capacity increases. That is what happens. So in this case, then you can label the person as iron deficiency anemia, and he or she starts showing symptoms of iron deficiency anemia. So this is basically the 3-step pathogenesis of iron deficiency anemia. Someone can be iron deficient, but it is not necessary that we will say that he is having iron deficiency anemia. On the other hand, if someone is having iron deficiency anemia, he is surely to be iron deficient. Are you understanding me? So that is the concept here. Now if I talk about the clinical features, then first and the most common clinical feature is the pallor. Basically what we do is that we examine the palpebral conjunctiva of the patient. We lower the palpebra or the eyelids of the patient, and we say the patient to look upwards, and it appears pale in a patient of iron deficiency anemia. Also, such patients may present to you as showing dyspnea, that they are not able to they're not able to breathe more, they are feeling lethargic. This is also a very common symptom. And then there's one more symptom which is called koilonchia, means the nail beds, normal nail bed, if I draw like this of a person, this is the finger, then the nail bed appears curved, spoon shaped. This is seen in the people or the patients of iron deficiency anemia. And one more is beefy red tongue. Why a beefy red tongue? Because the tongue undergoes atrophy. Basically the tongue has a lot of papillae and buds, but due to iron deficiency these papillae and buds atrophy and the tongue appears beefy red. So that is why the beefy red tongue. And alopecia, also hair loss, and pica. This is also a very important symptom. Pica, basically the patient presents with a habit to eat unnatural substances, like he or she may present to eat soil. He or she must say that Dr. Saab, I am having a lot of craving to eat soil. So this is also symptom seen in patients of iron deficiency anemia. And one more very important thing which is seen, which is rare, not that commonly seen, but it is seen in anemic females especially, and that is Plummer-Vinson syndrome. And you should rule this out only when that anemic female is also present with dysphagia. Then you should surely rule this out, because basically this is a triad of 3 symptoms. There is atrophic glossitis, and we see upper esophageal webs. If you do the endoscopy of such a patient, you will see, or the esophagoscopy of such a patient, you will see upper esophageal webs. And also there is a chance or a risk, and basically it may also happen that you see that the patient suffers from esophageal carcinoma, which is very disastrous, and that is also seen after the cricoid bone, cricoid region. I will talk more in detail about this when I discuss the anatomy of the laryngopharynx and oropharynx. So I am done with the pathogenesis and the clinical features. In the next video, I will be talking about the diagnosis of iron deficiency anemia. So I take my leave. Bye bye.